Daniel and Maria will admit people as they sign in during the meeting. And the whole meeting will be live streamed, recorded, and we will upload it on the International Society for Priorities in Health webpage later. So welcome to the first global web conference that the Society has arranged. It came as an immediate response to the COVID-19 pandemic, where suddenly over a couple of weeks, the topic priority setting was in all newspapers, on everyone's lips, and we all realized that our field of expertise, priority setting, suddenly became very important. And that is why we wanted now to have this first conference, where the main aim is, rather than giving very direct advice, we wanted to explore from different perspectives at the different levels of the health system, and learn from countries that are now struggling with the COVID-19 pandemic, how they have handled their situation. So the first set of webinars will be more explorative, and maybe later on we will try and look at if we can come with more concrete advice. And we have a very good list of speakers today, and the whole webinar will take 2 hours. We finish at 5 p.m. European time. We have Maralise Georgians from the World Bank, and we have Malet Kifle Abdemariam from Africa CDC. We have Yuan O from Seoul National University, and we have Hans Flotten, an intensive care specialist from Norway, and we have Trygve Ottersen and Atle Fredheim from the Norwegian Institute of Public Health, and Amanda Glassman from Center for Global Development at Washington. So as you see, it's quite broad. We have both policymakers, doctors, clinicians, and academics presenting. And I suggest we now just start with Maralise Georgians from the World Bank. She will give us an overview, if at all possible. She will do her best. And I have to say before we start that you all have to be very kind and generous, because all the speakers are at the moment extremely busy with all kind of tasks, so they haven't had much time to prepare. This conference we started planning this conference 6 days ago, and they haven't been given much time, so they have been planning in between all their other tasks now in the COVID-19 pandemic. But Maralise Georgians, she's a senior specialist at the World Bank. She leads a global program on data science and innovation in human development. And she has a lot of experience from working in low and middle income countries. She has been working for the government of Malawi. And she is now going to give us an overview of the COVID-19 pandemic. Maralise, have you unmuted your microphone? We cannot hear you.
Hi, is that better? Can you hear me now?
Yes, now we hear you perfect. So I welcome you to this conference, and you can now start. Thank you.
Excellent. Good morning, good afternoon, good evening, everybody. Thank you very much to ISPH for the invitation. I think it's a very dynamic time, and I've noticed with interest that this meeting is being recorded. I almost feel that the minute the recording is over, the meeting content will be outdated, because this is such a rapidly expanding and rapidly moving area. That said, I think we're all in agreement, and this is the slides and the map that we see from Johns Hopkins University that keeps track of all the confirmed cases. And the bottom line is, and as we all know, COVID is a global pandemic that is rapidly expanding, less so in developing countries, but just because there are no cases, confirmed cases, does not mean there are no cases. And I think we need to be very mindful of this. We have very limited testing capacity, and surveillance is only now coming on board in many countries in Africa. So the lack of red dots in low and middle income countries is not necessarily reflective of the lack of cases. And this is one of the many concerns in this area. I mean, there are so many graphs of this exponential growth, and we all know the immense and fast cumulative cases, just how infectious this disease is. And again, one of the challenges is, or infectious the virus is, one of the challenges that we have is exactly how infectious it is. There are some estimates that suggest it's about 4 times as infectious as the flu, as the seasonal influenza. Again, I think many of us have seen this graph. This just shows us the cumulative number of deaths in different places in the world. Again, developing country data not yet included here, but one would expect that to rise alongside other cases. This is a slide from Tom Frieden at Resolve to Save Lives that I really like. And what this slide shows is the measure of clinical severity on the x-axis and the scaled measure of transmissibility. And you can see for COVID-19 in the purple areas where we see the measure of transmissibility, which is high, where we see the scaled measure of clinical severity. And we of course know that severity and transmissibility as well is higher amongst older populations. The real question is, what do we do in this environment, and how do we respond in an environment where there are limited resources, which is of course the purpose of this discussion on on priority setting. This is another slide. Tom gave a presentation at the World Bank last week. I like this slide because I think it shows us the range of the different responses that are needed, all the way from containment on the left, mitigation, suppression, to long-term prevention of future waves of the pandemic in different parts of the world. And what is the different areas that we need to focus on in terms of coordinating the response, disease control, non-pharmaceutical interventions, supporting society, as well as the pharmaceutical interventions that we expect to come on board as well. Again, within the context of priority setting, the question is, when do we start which of these interventions? What is the relationship between this and routine services that need to be provided? How do we help countries make fast and rapid decisions in an environment where so little is known? We have, the World Bank has a large COVID-19 program, emergency fast track facility that we've created, and I will share a little bit about that. One of the challenges for us in the context of that fast track facility is I am part of the team that is advising all our task teams and countries, and I feel we need to check the literature every morning to make sure that the advice that we're giving is still the best possible advice out there, because this is such a fast-moving environment in which there is such this is a virus that's at the edge of medical knowledge. There's so much we don't yet know, and how do we make priority and good decisions in that context is something that I think is critical and for us to explore. With that, I wanted to mention just a few points about what the bank's response has been and the bank's program. So the bank has initially approved a fast track facility to the value of $14 billion. You can see the details here of new IDA, new IBRD financing, as well as reprogramming of existing financing. This is any IDA or IBRD country is eligible to receive this support. And there's also financing from the IFC available. Last Thursday, I'm sure many of you would have seen that the bank has approved the larger financing fast track facility for COVID-19 that would stretch up to $160 billion and would of course involve interventions beyond the health sector intervention. So it would look also at protecting markets, it would look at protecting businesses, it would look at protecting households and the immediate and important social assistance that is needed. In other words, how do we look at both protecting the economy and protecting human capital during and after the COVID pandemic itself? This shows you what is the theory of change and what is it that we're trying to do in terms of short-term and the more longer-term results with this COVID-19 fast-track facility. Now, if we move from what the bank is doing to respond and what we see as the priority areas, and again, this is from the 19th of March in this fast moving world. It feels like this is already outdated, and we know that it is, but this gives you an idea of what is countries' preparedness capacity. So based on the number of cases, what is their level of preparedness? I think and I'll show you the next few slides, the key message here is that countries are at varying levels of preparedness, and that of course getting preparedness to a stage where we feel confident no matter how many cases a country already has, what its level of preparedness is. We want more countries to be at levels 4 and 5 than countries to be at levels 1, 2, and 3. And the extent to which, as part of this priority setting in this environment, if we can make sure that countries move to the left is really what we're trying to do, and the support that the bank is helping countries to provide. This just shows you for all the other response categories where countries are. Not surprisingly, more developing countries are in levels 1, 2, and 3 than in levels 4 and 5. And I think this is where we need to particularly pay attention. Just out of interest, I saw an interesting analysis that was published yesterday from the University of Austin in the US that showed that even in counties in the US where there are 0 cases, 0 confirmed cases, there's still more than a 50% chance that there's already an epidemic outbreak. And I think this is a real challenge that low and middle income countries are having to deal with, is that despite the lack of confirmed cases, we might already have epidemics, and how do we best respond in those environments? I think fair to say that if we look at low and middle income country responses, they're on a continuum, as it has been in high income countries as well, ranging from measures still to be implemented and early action, rapid lockdowns with very strict requirements. I'm from South Africa. South Africa's Minister of Health made this point that they have decided to institute very early and very strict lockdowns, much stricter than what I've seen in any high income country. For example, in South Africa, you're not allowed to walk your dog, or at some point in time, they lifted that restriction, but even the purchase of alcohol was not allowed during this time. So very strict measures, very rapidly, and I say, in some countries, very forcefully implemented. I think we've all seen that that there has been some unfortunate cases of security forces getting involved in different low and middle income country settings, but there's been that responses, and there's been countries who have lagged behind in their responses. And I think as we think about priority setting, we have to think about setting priorities for these countries in the different stages where they're at. The next 2 slides, and I'm not going to go through all of them, but the next 2 slides really points to some key points about the epidemic and response to date that I think is critical for us to look at when we think about vulnerability. And my apologies to everybody who's watching this slide, that this looks more like text that was copied and pasted. As Kel said, we've not had a lot of time to prepare, and it is an immensely busy time. So sorry that this is not a very visual slide. I think important that we know coronavirus circulated without detection in many countries, and I think it's fair to say that we would have strong suspicions the same is happening in low and middle income countries. We do know that what happened in Italy was a perfect storm, right? Where we have a very large disproportionate elderly population. Spain is obviously closely linked to that. There is a high urban concentration, and one of the urgent discussions that we're having at the World Bank is with our colleagues working in urban slum informal settlement areas, because where there is high population density and lack of and water and sanitation services is typically done in a communal way. I think the fear is that corona can spread incredibly fast in those contexts. We know the deaths, and I showed the case fatality rates. We know the challenges with the case fatality rates in the absence of a strong measure of who is infected, but still case fatality rates amongst the vulnerable, I think we'd all agree, is much higher, despite an overall case fatality rate of, I think, 1.38% was the last imperial estimate that was published last week. Of course, health workers with repeated high exposure. And we've also seen some studies showing that viral load, in cases of patients with highest viral load, have the highest risk of severe disease. So repeated exposure is, of course, incredibly important. Um, Protecting the vulnerable and hospital capacity, if we can do that, then we can bring the mortality rates down. But doing that well and doing that early and doing that in countries in a ways that make sense in low and middle income countries is incredibly important. Um, Let me just on the next slide shows that social distancing measures, we need to carefully think about how they are enforced and what the large scale nature of them look like. We need to make sure that where lockdowns are done and where lockdown is the measure of social distancing, which is not always necessarily the case, but where that is the case, social assistance is needed urgently. If we are going to shut down informal traders that provide food, if we're going to not allow cross-border activity in terms of food being imported, then the reality is that even if we provide cash to people, they won't have a place where they can actually buy the food. And we've seen this in cases where there are lines a mile or longer for people queuing to buy food from informal traders, which is kind of negates this concept of social distancing, because people queue and they're very close to each other when they do that. I think we're all in agreement that testing, both PCR testing for diagnostic purposes and antibody testing to understand the range of asymptomatic, mild, severe disease in a population and people who've already recovered are of course really important. A real critical question for priority setting is which priorities count when, in terms of when lockdowns happen and just how we roll out these different services. Mathematical modeling, and we're busy formulating a global partnership with some of the modeling organizations doing the main players in this COVID modeling space, but that we and hope to be working closely with Africa CDC, who's the next speaker today. But modeling is so essential. We've seen that as we get more data, adjusting the models, helping governments figure out when and how to release the social distancing strategies. I think we're all in agreement that it can't be done simultaneously at once, but how we release them, how we make use of antibody testing, how we make use of other mechanisms without creating labor market distortions. All those things are incredibly important as we think about not just the social distancing measures, but when they are released and other measures are put in place as well. So what would be areas that we would say for the government to prioritize? And I feel like this is not a priority list because the list is so long, but of course, basic disease outbreak capacity, these 8 pillars of WHO's comprehensive response is incredibly important. I did want to say a few words about what are all the questions and particularly the answers to the questions that we need, and why surveillance and case detection, but also case reporting is so incredibly important. Mark Lipschitz did this excellent overview, and it was published in the New England Journal of Medicine last week, about what are the 4 critical questions that we need to answer. And to me, a number one priority is for governments to have either from their own data or data from other countries, the answers to these questions, because without the answers to these questions, it's incredibly hard to plan both which interventions you're going to implement and how the health sector can best respond. So what is the full spectrum of disease severity? There are some surveillance, population-based surveillance data coming out today and tomorrow that we're all very keenly following to understand what is that pyramid of disease from asymptomatic to pre-symptomatic, but to symptomatic but mild, severe, and those requiring hospitalization to what's the overall mortality rate. The transmissibility of the virus, obviously, who are the infectors, how do different conditions and how do different characteristics from a genomic level all the way through to a socio-economic level influences a person's likelihood of becoming infected. And can we use some of this, can we use machine learning and other tools to identify both the places and the populations we need to protect and then rapidly move towards protecting them. Our urban slum colleagues, for example, in the World Bank working on urban slums, have identified using satellite images what are particular neighborhoods where there is both high population density, lack of health facilities, and so lack of ability to do good surveillance, and how do we get services to those areas first, and in a much scaled up way. And then obviously, what are the risk factors for severe illness and death? And we really need the answers to these questions to be able to move ahead quickly. I'm going to end with these last two slides because I realize that I have 3 minutes left. The first area is what are other areas for the governments to prioritize. I really think it's important that governments focus on how do we control the COVID-19 infodemic. There is a mountain of applications, of tools, of theories, of apps, of different tools that people have created to communicate information about COVID-19. Not all this information is correct. We've heard everything from 5G network spread COVID-19 to a lot of other information, some of which is partially correct. There are lots of risk trackers out there now, symptom trackers, risk scores that people can develop, different apps that are out there. We need to make sure that whatever these are, they're done in a way that provides the correct information, that neither stokes mass panic, but also doesn't put people at a false sense of security. The whole issue of evidence and cost benefit analysis, which is of course a critical component thinking about this priority setting conference. We're operating at an incredible speed in an environment where we don't always fully understand or can anticipate the full policy, social, economic, clinical, individual consequences of the actions that we take. So we need to make sure that we both collect the evidence and that we build in flexibility in these government systems so that they can measure and make mid-course corrections when needed. And collecting costing data so that when we retrospectively look at these, we can think about how to best respond in future pandemics as well, that we don't just learn for now, but we learn for the future. Innovation. I have not seen innovation as I have seen ever. They say necessity is the mother of all invention, but be it from ventilators to distributing plans for the 3D printing of masks to just about every area that you can imagine, some really innovative work on contact tracing that can be done without compromising a person's privacy and location information. There is such a wide range of innovations that are out in the market. It's impossible for me to list or describe all of them, but to say that I think it is essential that these innovations are both tested and that we have a good set of tools to make decisions. The bank has developed a checklist, for example, to help our teams decide which innovations is appropriate for this particular context, and to make sure that even where we don't have evidence of effectiveness of, for example, a contact tracing system, that we at least know and we've asked the right questions, that we make the best possible decisions in an evidence-poor environment. We need to plan beyond the immediate measures. What does the long-term preparedness look like? We need to think about next generation routine services. I would argue that from an epidemiological perspective, if we can have people receive routine health services, non-COVID health services, remotely in their homes, in places where they're not at higher risk or putting themselves at higher risk of becoming infected with COVID-19, that is, or with the virus that causes COVID-19, that's so important. There are tools out there today that one can rapidly scale up and stand up a basic telemedicine service. And I hope that many countries look at this. If we can keep our diabetes patients, our HIV patients, our TB patients, if we can keep them away from health facilities where they have to pick up their drugs on a routine basis for routine care, vaccination services, all of these services that clearly need to continue, but we provide the services in a different way at a different place so we can move on. And then we need to mitigate the mitigation efforts, right? We need to think about gender-based violence, security concerns, the immediate social assistance, maintaining the food supply chain, education, distance learning considerations. And these is just a small list of the bigger picture of mitigating the mitigation efforts immediately and into the future that we need to think about. I'd argue that how do we think about human capital formation in a time of COVID-19 is incredibly important. And we need to think about planning the next phase. How do we not just undo the social distancing mechanisms, but at what point in time do we undo them? This is some recommendations from the American Enterprise Institute as to when and how one can think about releasing some of the social distancing mechanisms, and what is some of the concomitant efforts that need to be put in place to ensure that a health system isn't overwhelmed again in the future. And lastly, let me just end on this slide to say that I think as we've seen in COVID-19, this issue about how do we think about households, the access to services that they need, access to finance, assets and jobs, the macro fiscal public governance and resources component, and the social norms and media. We need to think about all of this when we think about how to roll back and how to respond to COVID-19 in a comprehensive yet pragmatic way, recognizing the environments in which we work and making the best decisions in an incredibly fast-moving environment. Thank you very much.
Thank you very much, Marlies, for a very good overview of the COVID-19 situation in different countries in the world, and also for opening up how the World Bank is now tackling this emergency. I have one question. You are a little bit over time, but the question could be hanging a bit in the air because it's a good introduction next speaker. So one of the participants asks, Africa is the last continent to face COVID, and what should we have to learn from the experience of China, USA, and I can add Europe to that. Yeah. So that's a very good question, and I think we can come back to it later, but it's something I think we can leave to my good friend Malet Kifle Habtemariam, working in Ethiopia at Africa CDC. In our research center in Bergen, we have been working with Malet for many years, and she has so many skills and experiences. She's a medical doctor. She has a PhD and has done very good research, and she has also been the Director General of the Ethiopian healthcare system, a country in Africa with 110 million people, and she is now the Principal Program Officer at Africa CDC. So she is a very competent person to raise more thoughts on the question that we got. So Malet, the floor is, the word is yours.
So thank you, Chalana, for the great introduction. Can you hear me well? Hello?
Yes, we hear you well. And Malet, could you please turn on your camera? Okay. So that we can see you when you speak. We have to try and make it as real as possible, even though we're all sitting in our home offices at this conference. Yes, now we can see your camera, and we hear you well, and we see your slides well. So please continue. Yep.
Good. So good afternoon, everyone. I'll start my presentation by providing a quick epidemiological update, which will be followed by a brief overview of what Africa CDC did so far to support African countries, and then we'll go straight to discussing the different challenges for priority setting in relation to the current COVID outbreak. So as of today, 52 countries have reported a total of close to 10,000 cases, 500 deaths, and 900 recoveries on the continent. The top 5 countries in Africa reporting the most cases are South Africa, Morocco, Algeria, Egypt, and Cameroon. This graph shows the cumulative number of cases in Africa compared to Europe. So what we did was we compared the cumulative number of cases during the first 50 days in Africa. That's after the first case was reported, and compared it with the first 50 days in Europe. And as you can see on the graph, we are on a growth similar to Europe, which is very alarming. And this is also in spite of the obviously significant difference in capacity in surveillance systems, and the cumulative numbers might even be higher. So far, local transmission is established in 39 of the member states, and 12 countries have reported only imported cases. We are still working with member states to see if some countries already have community transmission, which seems inevitable. And when we see the response of Africa CDC immediately after cases were reported in China, we activated our emergency operating center and developed our first incident management plan, which was followed by an emergency meeting with African ministers of health to discuss and endorse the continental COVID-19 response strategy. We have also launched a continental task force to coordinate the response with working groups under it, focusing on the different technical areas. So far, we issued a guidance document for social distancing measures. We also provided different trainings on different technical areas, including surveillance, IPC, and laboratory capacity building for testing. As you can see on the slide, only 2 countries, Senegal and South Africa, had the capacity to test at the beginning of the outbreak, but now 43 countries on the continent can provide the testing. And apart from this, we are also working on distribution of test kits and deploying rapid responders to meet member states' technical assistance needs. So when we come to the priority setting challenge, I will try to discuss them one by one on the consecutive slides. So the first and major, I'm sorry. Okay, so the first and major challenge is lack of data and evidence. And this starts from defining the people at risk in Africa. The single most important risk factor for severe illness and days elsewhere is increased age, and the risk of days increases after age 50, then markedly for each decade thereafter. And also other comorbidities such as chronic heart disease, high blood pressure, and smoking, or chronic lung disease were also shown to increase the chance of having severe diseases and dying. But when we see
sorry, Mollet, to interrupt, but we have a very nice slideshow living its own life now. So I suggest maybe you could, if you want to have more control of the slides, maybe you could just turn off the slideshow and you could show them manually from the PowerPoint, or if you share screen.
Okay, my screen sharing is off now.
And then you can share screen with just showing the PowerPoint software. Yes, and if you enlarge this, now you have maybe a bit more control. That's an option. Or you could try one more time now to start it. What do you want?
Maybe let's keep it like this.
Yeah, that's good. Yeah, so we can, please continue.
Yeah, so what I was saying was on the African continent, the median age is 19 years, which would likely reduce the case fatality. But on the other hand, not much is known about the risk associated with other conditions that are common in Africa, such as HIV infection, tuberculosis, malnutrition, anemia, and also the significant burden of non-communicable diseases should not also be underestimated. Further, inadequate water, sanitation, and hygiene infrastructure will also increase the likelihood of the spread of infection, and the added health-seeking behavior and delayed presentation to healthcare facilities will also add to the increased vulnerability of the continent. And all the factors I mentioned above will make identifying the population at risk a very complex task. And when we come to healthcare capacity, the weak health systems on the continent, as well as the absence of critical care services, will likely add to the increased vulnerability of the continent. We have limited information on the ICU capacity in the region, but I can give few examples with the available data we have. For example, if we see Uganda, they have their 0.2 beds for 100,000 people, and Lesotho 0.5, Comoros 0.75. For example, if we see Somalia, they reported 0 ICU beds, so they don't even have a capacity for ICU care. We are still working with member states to collect and have a comprehensive data on this. And looking at this preliminary report begs for another question, which is on
sorry again, Mala, to interrupt, but maybe now the slide, we're at slide 9. Is that the correct slide? Yeah, okay. Yeah, so that just so that now you have to remember just to scroll down. Yeah, okay.
Yes. So and so looking at this brings a question on which interventions should be prioritized and whether to invest in prevention versus treatment or mitigation. So the other challenge is limited availability of modeling estimates. We have few of those exercises that we are conducting with partners and in collaboration with universities. But most of the assumptions, because of lack of data on the continent, most of the assumptions are adopted from elsewhere, which might not show the exact or the true picture of the problem on the continent, and which is making it very challenging to inform priority setting decisions. So the other thing is the trade-off between investing on COVID and other competing health priorities, which is not very clear. For example, as we speak, there are other outbreaks on the continent. We can see like measles in DRC, Lassa fever in Nigeria. And in addition to the outbreaks, the health systems need also to deliver on other essential healthcare services. And many countries are reverting to diverting resources to COVID response, such as, for example, like some countries are fully dedicating hospitals for COVID patients. And it's not very clear what the consequences of this would be. And also if the health benefits of doing so will outweigh the health loss from providing other services or from the lack of other services. So making choices among the different interventions that are recommended for the COVID response has also been a challenge. We do not have adequate evidence on effectiveness of recommended interventions to limit transmission, such as social distancing, large scale use of masks, travel bans, school closure, etc. In addition, consequence of introducing those interventions on the economy and other externalities is not very well quantified, and we also lack evidence on appropriate treatment options for seriously ill patients. For instance, choices need to be made on what proportion of the available resources should be divided between scaling up ICU care or like investing on mechanical ventilation for critical patients versus scaling up oxygen availability and associated services for moderately to seriously sick patients, and minimize the chance of patients becoming very critically sick. So misinformation and managing the public demand has also been a challenge, and this also makes making the optimal or the right decisions or like making the right choices very difficult. Urgency to act and the lack of time to conduct needs assessment enables decisions to be made without going through optimal decision-making processes. And the other challenge is unpredictable financing. It's actually a major challenge, which I believe most of the member states face as well, not knowing the amount of funding or if there will be any funding at all, which makes it difficult even to start discussion on priority setting. And timing of funding is also very critical. For example, in one of the background slides, I mentioned that most of the countries in Africa have either imported cases or local transmission. So investing now and using this critical window of opportunity might be better or might have better returns than investing later when there is a widespread community transmission. So the last but not the least is feasibility of interventions. Even though some interventions were shown to be effective in other settings, such as like flattening the curve, we need to critically look into their applicability in low-income settings. For example, if we see flattening the curve might not be as meaningful in settings where healthcare facilities are already overwhelmed. For example, Somalia reported 0 ICU beds. So what is the significance of flattening the curve in these settings? And this is not very, very clear as well. And the other thing is acceptability of some of the interventions that are being recommended in societies where religion has a bigger role and gathering for religious rituals is very common. Interventions need to be contextualized to become relevant. So these are like some of the challenges we face on a daily basis on prioritizing interventions for COVID and other healthcare priorities. Thank you for listening.
Thank you very much, Molet. This was very interesting, and I see it's a real challenge what you're now facing in many African countries, with both the evidence that you have available for making decisions and also the lack of resources and competing demands from other healthcare services. So, and the uncertainty with regards to how this will influence population in African countries with different contexts, and also the funding issue that you mentioned. It's a huge challenge. It looks like in the chat, people are very concerned about the testing capacity in African countries. So I wanted to bring some of these questions to you, Molet. So one question was, what does testing capacity mean, and have tests, does this mean to have the tests available, or is it widespread testing like screening?
So the way, so in the slide I presented, what I meant was like before the outbreak, countries were not even able to conduct the tests in country. They had to send samples elsewhere to get the tests done. But now around like 43 countries on the continent has the capacity that they can test in country. But it doesn't mean that they are doing like community-wide or like massive testing. I mean, there are like other challenges. Maybe only one laboratory is able to provide those tests, and also commodities, making sure that they have the necessary commodities have also been a challenge. So it only indicates that they have the capacity to conduct the tests in country.
Yeah, So thank you, Mollet. This was very good and important. And I suggest we continue with our with our program, with our next speaker, and we can continue the discussion later. So the next speaker is, I would say, in many ways, a presentation of a success story from South Korea. So Yuan Oh from Seoul National University will present experiences from South Korea. They faced the COVID-19 pandemic early, and they did things slightly different than what we have seen in many European countries and the US. And this turned out to be a success in many ways. So we really look forward to hear your thoughts about and presentation what South Korea did. And Yuan Oh, he's a medical doctor and a professor of international health policy and management at Seoul National University. At the moment, he is doing research in Boston at the Harvard Medical School. And he has for many years been working on priority setting in South Korea. So we look forward to hear your talk, Yuan.
Yeah, thank you. Thank you, Kezo. Let me share my slide first, then is it shared? Not yet. Maybe it is shared now?
Yes, now we see it. Yeah.
Okay, yep. Okay. From the South Korean experience, let me introduce the recent history, so that if you can see our structure of the priority setting first, then the top layer, the market only is provision that was not covered by public governmental coverage. That was not regulated much, only for safety and efficacy regulation by the FDA, by classic way. No priority setting is here. However, later on, I will show priority setting was done in this zero level, the market areas. The first layer is the standard coverage, 70 to 80% coverage, the financial coverage by national health insurance, and 20 to 30% of co-payment cost sharing structure. From 0 to 1, that is typical health technology assessment committee was working for this decision making. But previously, this decision making was not really based on the cost effectiveness. Mostly it's just the cost based. So budget impact is huge, then they disregard. If budget impact is small, then they accept. So that very crude decision criteria was going on in the past. So many important services was out of the list. Then recently, 7 years ago, we established a new health technology revisiting assessment committee. Then we reviewed all the out of our list again. Then we start to include more and more over time. That was done by another committee. That is much more based on the social value judgment, so that includes the social cost effectiveness and also other aspects such as severity condition and financial risk protection, etc., etc. And then more generous condition, more generous coverage was next level. That was more smaller 0% co-payment. That decision was done by, has been done by the disease-specific priority setting committee. Once they accept it, it becomes the smaller co-payment structure. Then last layer is regardless of any reason, if co-payment or direct payment or full payment goes beyond some income level, then that committee give the rest of the spending is waived, so that can be reimbursed, so to provide the safety net. So that example, or the beyond some cut line, still that can be applied. Then the committee is tackling one case by one case in that cases. So by this 3-layer committee is now working. So last committee is much more like a financial risk protection based. Then next committee is much more words of the severity based. The other is that. This is the typical structure. Let's go to the COVID-19. After Wuhan, China, then South Korea became the second affected countries. However, luckily, we have flattened the cumulative epi curve so that now we are almost relieving, while the other, unfortunately, Italy and Spain, now US is attacked and so much highlighting accumulated curve now. So how can we do that? That can be introduced. If we zoom in, the course can be divided into 5 phases. So 0 phases are no cases, only in the China as epidemic. Then phase 1 is 1 sporadic cases, 1 or 2 per day. Then second phase is more likely increasing. Per day, it is peaked at 909 cases per day at the end of February. The beginning surging is February 19. That is the 31st super spreader patient cases confirmed day. That super spreader spreaded the sitting to one big cluster is much more several thousand of people. This cluster became now almost 60% of whole affected people in Korea. Then third, declining fourth plateau phase we came. So I listed some 13 priority matters in our Korean experience. I'll visit one by one from the next slide. From the 0 phases, what I did is we prioritized diagnostic capacity development and then rapid approval. Then while we are postponing the other approval process for other diagnostic tests or drug approval cases, so that we prioritize COVID-19 diagnostic kit first. The opportunity cost might be not high in this time, so quietly but promptly we did. At the next phase, the sporadic incidence phases, we did 2 things. One is most of KCDC officials reallocated to our airport to special quarantine from the incoming traveler from China, Wuhan. Then most of people are working there. So during this time, no other ordinary work was spared for several days, several weeks. And second one is we did undetermined the pneumonia admission cases of the all national levels, maybe 3-digit number. We screening all the pneumonia cases admitted. Then amongst that pneumonia cases, we found out the 31st patient who turned out to be a super spreader. If we didn't do this prioritized the screening test, aggressive screening test, maybe we found out that case is very late after very big spreading. So this is one good luck for us by the aggressive prioritization of the screening test, applying for the very wide range of diagnostic test eligibility. And next phase is surging phases. That during that surging phases, what we did is much more typical clinical setting rearrangement, reallocation of the resources, and then also preventive services reallocation of the resources. Both are very much typical one, not very special. However, we did this very rapidly, and this decision was done by the presidential office level. This decision is very political. This was not done by the priority committee pathway. This was directly done by the president office decision, then Ministry of Health, and then KCDC together with the provincial and local government. So by doing that, if I introduce a little bit more, it will be helpful for you to understand the next slide for priority setting perspective. So for the preventive setting, we did a very aggressive case tracing, then contact tracing, and then active the diagnostic test, and then the isolation, and also some physical distancing very early. Then also for the treatment system rearrangement, we established a triage system, so that after having triage system every district level, 250 districts in Korea, then based on that triage, we made a new pathway, the patient flow. One flow is COVID flow, one flow is the other non-COVID flow. Non-COVID flow is basically same as previous one, but COVID flow is a little bit vertical pyramid. So totally we made that not interchangeable within our hospital. And even tertiary hospital, it can be inevitably, the both system is in one hospital, in the university hospital. But for the general hospital, secondary level, we did not allow for the intermingled one. Only COVID hospital or only non-COVID hospital is allowed. Then the other first level, the primary level, we transiently made a very specialized accommodation center to observe the clinical manifestations progress toward the more severe way. Without doing that, maybe we have many more deaths, which was observed now in the Europe and US. So we developed the dormitory, non-clinical, the dormitory system, the dormitory facility into clinical observation the facilities. By doing that, we found out very good progress toward it was transferred to secondary, tertiary. Then if you go to priority setting perspective, we prioritize COVID more than a non-COVID condition, but we didn't sacrifice much about the non-COVID conditions, which was observed quite often in many other countries right now, which is overwhelmed. Then public safety, it was much more prioritized than private privacy. While we are opening the pathway of the affected person, then inevitably privacy was opened. But later on, we amended that lowering the privacy open, but at the beginning phases, privacy was not really well protected. Then third one is diagnostic test was much more prioritized for all contact tracing, active tracing cases rather than symptomatic cases for eligibility for diagnostic test, which was done more in US at the moment. And the other human resources prioritization and the hospital bed prioritization, ICU ventilator, ECMO, or respiratory medicine specialist prioritization. There was not much sacrificing other disease or other facilities. We did it quite smoothly, even though a rapid reallocation was. Then next, the declining phases. Declining phases it's much more better than before. However, chaos was coming this time. So people would like to wear the mask, but mask production was not limited, not reached to the demand level. So shortage was huge. And then also, even after the production rate is higher, then still distribution is not good. So that the people cannot buy timely. So that blame to the government was huge at this time. Then another one is after giving social distancing encouragement, then people's visiting to restaurant and bar and then the cinema was halved and then 1/3. So that economic downturn began. So people are kind of socially and economically risky. Then now society began to discuss about the transient basic income for some fixed amount for everybody. Then last, these days, the plateau phases, we handled a little bit these two chaos things much better. Mask, we increased the production rate so that our government made this mask as if it is a public goods, even though it is private good. People need to buy it by paying some money. But the amount of the provision was strictly regulated. 2 masks per 1 week per 1 person is highly regulated. That regulation was monitored by the drug utilization review system, strictly reviewed. So 1 person only buy that. Then the other purchasing control and also stock information disclosed by the smartphone app that was developed like Taiwan. then that was applied. But additionally, our purchasing control by the DUR system. DUR is originally drug system for drug, but drug prescription overlapping prevention program, but this was done for mask as well. Then the other basic income for disaster relief, that was now quite converged. So society was almost going to pay this money to almost everybody. Now last debate is for all or for 70%. But I guess it can be quite all for disaster relieving. I'll quickly review the priority setting practice performance-based, so that well-managed priority matter might be listed and summarized like this. Mask, finally, we controlled very well. Then COVID versus non-COVID, we didn't sacrifice too much for non-COVID while we are prioritizing COVID condition. And also the diagnostic test eligibility criteria was also prioritized for all contact tracing cases. And also it is not overwhelmed the diagnostic capacity of the daily capacity. The bed ICU, respiratory medicine specialist, and that was not overwhelmed at the moment because of the early aggressive containment that was not making the curative system overwhelmed. So the next category might be not bad, but not well managed priority matters. There might be still basic income. The economic downturn was not fully compensated. Still, we should manage that very well. And privacy issue, we began to protect it, but not fully. Then the other personal protection equipment, we utilized that a little longer than standard recommendation date for some epicenter in Daegu city, and also shortage and or fatigue of physician and nurses in that epicenter Daegu for long run activity, partly because government or Korean Medical Association has no authority to mobilize, reallocate all the human resources into epicenter. So they voluntarily sacrifice their time. So their fatigueness level is a little bit higher. So this is not really well managed, but not being matter. No publicly debated about the mask waste control. It might be environmental harmful, but future generation may complain about this, so that we need to tackle later on. So lesson learned might be, if we can anticipate demand very well in advance, then supply can be prepared quite early. Then if we expect a limited resource for the supply perspective, then fair distribution with the priority setting, more sensitive priority setting might be necessary, like our mask cases. Then if priority is matter, then unfairness appeal is coming, then adjustment can be done. Then another limitation might be cost effectiveness was not really considered very well because of insufficient science-based knowledge yet. And also deliberation time is too short. And also worse off and severity and financial risk protection perspective was not really balanced with other diseases. This is prioritized only for the COVID in this aspect, but legally already determined. It's much more like a health security oriented legal framework. And human resource reallocation was not legally prepared already in advance. So this was a limitation of our action. The last slide, maybe the main question in priority setting might be, we did it quite good. However, this might be the rule of rescue perspective actions. Most we prepare present health first rather than future health, and also urgent health first rather than chronic health, then population security first rather than individual health, so that rule of rescue principle was good for urgent phases. But we can think about that. This can be same things. If similar things happen in the future, then we need to change it or we need to keep it. Thank you.
Thank you very much for an interesting presentation, Yuan. I had tons of questions when you presented. It's such an interesting case, and you have done it differently than many other countries. We got some questions in the chat. Still, it seems like you were very active in doing testing. So one question was, why did South Korea successfully expand the capacity of PCR testing, and how did the government lead this process? Because this seems to be crucial for the success. You were early and you scaled up massively with PCR testing.
Yep.
Can you comment on that?
Yeah, can I answer right now?
Yes, yeah.
Okay, yep. Briefly speaking, we had a very painful memory in the 2015. Maybe some of you can remember MERS-CoV. That was Middle East respiratory syndrome. That was originally Middle East disease, but it was affecting our country. Then the fatality was so high, then many KCDC officials was punished. Then many lay people were very painful memory from that time. So our government was prepared for tackling next epidemic quite in advance, so that once China was epidemic, we didn't just see that, we were preparing how to overcome if that disease comes to Korea, not to get the same experience as MERS-CoV. So actively, we developed the China specimen, using China specimen, and to develop the PCR diagnostic test, and then rapid approval was done. And the scale up of the diagnostic test, the time duration should be shortened. So many diagnostic expertise are hardworking to do that. So day and night they worked. So that might be secret.
So that's interesting, and it sounds like also this had an impact on a lesser impact on the economy compared to what we now see in other countries, because you did not have to totally lock down South Korea. You could have the borders open and you could have shops open. So the economy had were much less affected than we were in other settings. So this was very interesting, Johan. I'm sure we will have good discussions later on. So now we continue. We have been now at a population level discussing globally and in the continent and in an African continent, and also at a national level, looking at public health initiatives. But now we will go to a clinical level, and we have Hans Flotten, who is a specialist in intensive care. He has been leading a lot of interesting work in Norway and globally in intensive care. He's a professor in intensive care, and he has been central in the European Society for Intensive Care Medicine for many years. He was also involved in a conference last weekend on COVID-19 and experiences in European countries and elsewhere at the intensive care units with COVID-19. So Hans Flotten will speak about the clinical perspectives of COVID-19.
Yes, thank you. I will not deal with how to treat them in the ICU, because that would totally go beyond my time. So I will deal with priorities and some concerns seen from the floor of people who treat these patients. And as you said, I'm working here in the Haukeland University Hospital. We've seen a lot of news coming out from this pandemic from other places in the world. And I thought I would first focus on who are we treating. And this in particular is relevant for the high income countries, I will assume. This is from New York Times, April 1st. Patient has a virus and serious cancer. Should doctors withhold ventilator? And the mayor in New York is concerned about if they cannot treat them all. And you see in the picture, there are triage tents outside the New York Columbia University Hospital. On the right side, you will see that what's written. One patient had lymphoma and heart failure. Another was 85 years old with metastatic cancer. A third was 83, had dementia and lung disease, all critically ill, and they were hooked up to ventilators. This is, of course, a problem, and I will deal with that, how we, at least in the Nordic countries, look upon who to treat, to triage, to intensive care when they come that critical ill. And I know that some of my talk may sound provocative for some of you who are used to think otherwise, but that is good maybe for the discussion afterwards. I will just focus on some research we've done in Europe. We have had 2 large European studies performed last 3 years in the critical ill elderly population, because we are coming into a tsunami of elderly persons in Europe, and they also will come to the hospitals. And the VIP study was on frailty and outcome, where age was found only to be a weak predictor for mortality. And in the VIP2 study, interactions of 4 geriatric conditions on outcomes were studied, and they again found that frailty trumps them all, both cognition, comorbidity, polypharmacy, activity of daily life. And we used a very simple frailty scale called the Clinical Frailty Scale, developed in Canada by Rockwood and co-workers. And here on the right side, you can see the graph. This is nearly 5,000 patients, about 80 years. The blue line is those acutely admitted, and these are elective admissions to the ICU, because these are 2 different cohorts. And you can see there's a near linear relationship to mortality and degree of frailty in the elderly population. And when we investigated it further, we also saw that the odds ratio for 30-day mortality, the frailty scale, or the increase in frailty, was dominant even above organ dysfunction. So back to New York, it's about ventilators, and in the Western world, it's all about ventilators. We have the opportunity to treat a lot of these patients in the hospitals, and then we are confronted with problems. We do not have enough ventilators. And just to show one example, here are 2 people sharing 1 ventilator. I'm not sure that's the best option seen from a purely clinical point of view, but it's shown how desperate people are when you lack essential equipment and you try to do something for them. This is non-invasive ventilation, where it's probably possible to share a ventilator, which is more difficult if you intubate them. Another problem recently published in US Today, in fact in Chicago Tribune, is that there is a large difference in outcome according to race of a person. On the left side, we see that the percent of Chicago population is roughly 1/3 Latino, Black, and white. And the percent of COVID-19 cases is dominant in the Black, but the most astonishingly is that a percent of COVID-19 deaths in the population is nearly 70% Black Americans, very few white and Latino. This, of course, could represent that this population have problems before they are getting ill. So it does not necessarily mean this is genetic or some racial thing to have less possibility to withstand that infection. But it is interesting that even within a small community, the outcome of this infection is very different in different races. If it is a genetic trait, then of course Africa will maybe be worse off than Europe. But it's just a new thing coming in. As a previous speaker said, we get information each day that makes it necessary to change priorities and the way we handle these. And that brings me how to deal with this challenge. And this was from New England Journal of Medicine some days ago, about how to allocate ventilators in a pandemic, the toughest triage, because allocating to a ventilator is the same as allocating them to intensive care. Because when you admit a COVID-19 patient to intensive care, it is because of an acute respiratory distress, acute respiratory failure. They advocate that using a triage committee informed by experience in the current pandemic and prior written recommendation that can help personnel on the floor and relieve them from the emotional, spiritual, and existential burden. And advantages is that the physician and nurses caring for the patient, they can maintain their traditional role. And maybe this is so in America, but it's definitely this way in the Scandinavian countries, where we have a different approach to triage. Interestingly, from Italy, they have nearly no triage criteria prior to the tsunami hitting the northern part of Italy. And we've seen a lot of photos from the intensive care, from the hospitals, where it's really a chaos. They were hit by a COVID-19 tsunami and they were not prepared. And they started to treat all of them. And we have seen a lot of misery coming out from this. So no, for 10 days ago, the clinical ethics recommendations for acceptance into intensive care treatment was completely reversed. And now they introduce an age limit. And they, of course, point that the older the patients are, the less they will live after, even if they survive. And it should be the probability of survival and maximize the benefit. They also admit that functional status and comorbidity has a priority, but I'm not sure whether it's stated after or ranked after the age limit, and then they do functional status and comorbidity. Probably we in the Northern Europe will have functional status and comorbidity first. They also have this distributive justice when resources is overwhelmed. Distributive justice may ultimately be justified. They don't get into details here, but it's interesting to see that they have this up. They also point of the ICU trial, which we are very familiar with in Northern Europe, in the Scandinavian. We admit patients, although we have doubt that they will profit from the admission. And we have an ICU trial, the first 2-3 days, see how it goes. If there are no improvement, or on the contrary, maybe they get worse, we are rather quick to end the ICU treatment. And so it's an end-of-life decision taken, and the patient most usually die in the ICU. And this is also in Italy, as we have in Northern Europe, a responsibility from the staff. In Europe, I don't think anyone has a separate committee that on behalf of the staff take these decisions. We think that the staff that know the patients, know intensive care, are better suited to do this themselves. So who shall be given intensive care and bedside priorities? We have discussed it, and we think it's important to be open to the society about these priorities. How are we thinking about who will be given intensive care and our priorities? So we've had several debates in major newspapers in Norway in order to highlight this and to offer our opinion to the public. As far as I understand, and this is from prior to this pandemic as well, the public is very satisfied with the way we do it in Norway. Although, of course, there are sometimes discussions and problems. I will not say it is not, but what system you use for triage, it will sometimes always create difference in opinion. On contrary, with a lot of other European countries, our elderly population does not usually stay home with the rest of the family. They are in nursing homes. So we have, in a way, cohort isolated them before the pandemic, to say it a rather rude way. They are there and they will be there. We have had thorough discussions with the geriatricians and nursing home physicians who care for these patients that if an elderly person is so frail that they have to come to a nursing home, they will probably not profit from going to intensive care. So nearly none in the present pandemic of patients in the nursing home, and that's the elderly part of our population, are referred to the hospital and they are not going into intensive care. I know this is controversial, but it's the first time we've had this agreement across specialities, intensive care and geriatrics and nursing home physicians. And I'll leave this open to discussion. Also, the Norwegian Director of Health have recently come up with some prioritization that we should follow with regard to healthcare in general. And they also point out that patients in nursing home should be treated there. So in a way, we will avoid admission from nursing home. We make, of course, exception in very special circumstances. There are those going there for a short time training period, for example, and may be less frail than the rest. And we believe strongly that those in nursing homes will be better treated at the spot, maybe with oxygen supply, comfort and care, in comparison with transferring them to the hospital. It's a strange new environment. A lot of them have dementia. They do not know what's going on. And I've seen several of these patients and I feel sorry for them being dragged out from a way of living that they know and they have confidence in. So we put specific weight, you can see on the right side, the degree of frailty, and we try to measure frailty using the same scale. And then, of course, we also put weight on end-stage organ chronic failure, like COPD, chronic heart failure, chronic renal failure, and also end-stage cancer disease. Then, in addition, age can be an additional factor to the above-mentioned group and not as an isolated factor. So even though I've said what I've said about the nursing home, this is not because they are elderly, it's because they have a high degree of frailty when they come to nursing homes in Scandinavia. I also must confess that intensive care is a luxury problem. Here we see the pyramid recently published in the Lancet. Only 5% of all clinical cases of COVID require care in the intensive care unit and mechanical ventilation. The rest requires proper ambulatory care, and 15% approximately require essential care of critical illness or oxygen without mechanical ventilation. And on the world basis, I think we have to prioritize the bottom of this triangle to try to cope with the pandemic. So lastly, a personal ethical dilemma. In what degree have healthcare workers a duty to work also in the pandemic? This is a question raised by a lot of healthcare workers worldwide. Do we have to work? The answer is probably yes. I say probably because it's discussed. The problem is, of course, if you do not have protection equipment, as I will come to. And this is a reality. More than 60 doctors in Italy have died in the present COVID-19 pandemic, and a lot of other health personnel as well. So this is not only a potential threat, it's an actual threat to health personnel that goes in and do the intensive care in particular, because then we are very close to the airways in many ways. We have to intubate them and care for the airways. So what then if there is not enough protection gear? And James Taberry, that's somebody you might know, says in a notion, if hospitals don't have a personal protective equipment, they are in no position to tell their staff to show up and work. This is also a little provocative, but as a healthcare worker, I'm glad he says so, because then he puts pressure on hospital to provide enough protection gear for sending their personnel into the battle about coronavirus at hospitals and also other places in the society. So with this, I end my short presentation about some clinical points from the present COVID pandemic, and maybe there are some provocative things I've said, and I'm happy to join the discussion afterwards.
Thank you very much, Hans, for, well, I wouldn't say it's very provocative from at least my perspective, but you raised a lot of interesting challenges you face in the clinics, and it's interesting to see that you don't put emphasis on age in itself in your decision, but frailty is more important, because that is a better prognostic indicator for the effectiveness of treatment. So frailty seems to be important, and then you add emphasis on age after looking at frailty. So that's a bit different than what we have seen being discussed in many newspapers all over the world looking at triage. There were some questions coming to me, and one question relates to if you look at the intensive care unit rate per capita in different countries. We know that in Europe, this varies between 5 up to 30 per 100,000 people in the country. And in China and India, it's around 2 to 3 per 100,000. And in the US, it's around 30 per 100,000. So my worry, and I guess that also goes for the person who asked the question, is, but if you look at low and middle income countries, this rate is much, much lower. And then we're talking about less than 1 per million. So then the question was, is there a way we could work on this globally? How about the feasibility of telemedicine and telehealth to support African nations as far as global solidarity is concerned? Is this something you discuss in the intensive care society?
We discussed it, but not in the context you drew up now, because I do think that in particular African intensive care is very little known, what they do or not do in the Western world. And it is, as you say, they might have 1 intensive care bed per million people, showing that intensive care really does not matter in battling that disease in many countries, because that 1 ICU bed doesn't, make a really big difference. And maybe then you should give priorities to the bottom of this pyramid I showed, and in particular the middle one, where you have enough oxygen. Maybe that's more important than having a ventilator available. And I say that because I do think we also, in such countries, it will be maybe a waste of resources to give a very high priority to those few that is available to go to an intensive care unit, at least in the present state. I hope in the future they will have more intensive care, because it's an asset for a country to have in many different circumstances.
Yeah, I agree, and it's a good point. But also another question here, because you illustrated also in a nice way that Norway, we have a strong tradition for priority setting within hospitals, and doctors are being trained in priority setting, and we have good guidelines for bedside rationing. But then a question from Aviva here is, what lessons are there for countries that don't have existing triage frameworks in place, especially in low and middle income countries? Because as you said, I found it interesting also that you were quite active in you called it ICU trial, where we start treatment, but you were active in stopping ICU treatment if you saw that this was not going anywhere. But what advice would you give to countries without good triage guidelines?
Again, most of these countries does not have a lot of ICU beds, as we said earlier. So I do think that triage to an ICU bed that does not simply exist is, of course, just a theoretical thing. And that's why I think it's more important to offer patients proper care and giving them oxygen, because with oxygen you can save a lot of lives in these patients, and not only those maybe 25% to get more ill, 25% that needs intensive care. But I agree that priority setting is difficult when you don't have a unified way to think about it on a country level, and then it has to be on the hospital level or on the individual level or group level that decides how to deal with this in the best way.
Yeah. Thank you very much, Hans, and we will come back to these interesting topics in the discussion. But now we continue to another Nordic presentation, and we are very lucky to have Trygve Ottersen and Atle Fredheim from the Norwegian Institute of Public Health. They will have a joint presentation, and they will talk about the dilemmas they have faced now in the early phases of COVID-19 pandemic, giving advice to the government in Norway on what to do, and they don't always listen. And sometimes you agree, sometimes you don't, and there are lots of difficult priority dilemmas. And you will particularly also talk about the case of school closures and what we should recommend to Norway now later on. So Atle and Trygve, the floor is yours.
I hoped that Trygve would start.
I will start, yeah. So we have divided it up, so I will do the superficial part and Atle will go into some substance. That's how we normally do it. So if you can just show my one slide. So now we're moving away from treatment and out of the hospital to discuss public health interventions that have the aim of reducing transmission. The slide is
it should be in between.
My beautiful slide. Okay, I can explain.
It's there. I don't know why it doesn't come up. You see it now?
Yeah, it's just crossed over or hidden, it seems like. But we might show it just like this, or perfect. Okay. So now we are moving out of the hospital, looking at public health interventions to reduce transmission, and we will focus on non-pharmacological interventions, so not vaccines and all the very important issues regarding vaccines, but then more hand washing, respiratory hygiene, quarantine, isolation, school closure, as Atle mentioned, restrictions on mass gatherings, and physical distancing more generally, and some of this also applies to trade or travel restrictions. So I mean, and I must say, since this is really a conference or seminar where we try to look across settings, that of course I think a lot of these considerations applies to most settings, but how one balance this and the values that one actually brings into this deliberations, of course, vary in addition to the situation on the ground. So so this is very, more generic considerations, but at least here in Norway and in the literature, it's quite common to start off with considering the effect of the measure when one are about to choose what kind of public health measure to implement, to start with the expected impact on transmission of disease, and that's the green cell there. Of course, there we have quite limited evidence. So both either we have to look for evidence from other pathogens or in other settings in other countries. And one dilemma here is what it means to be cautious when the evidence base is so poor also for some of these quite intervening interventions. So that's kind of the first step often. And the second step is to look at the negative impacts of interventions like physical distancing, closure of business and schools and so forth with respect to the economy. So as we all know, a lot of the discussions is about the trade-off and the dilemma between reducing transmission and avoiding to harm the economy. But of course, that's too simple in many ways, given that the downstream effects of challenges to the economies obviously can impact health, both because people lose their job or the psychological effects linked to an economic downturn, but also that the health system will have less resources downstream and so forth. So as I think all of us in this seminar are thinking, this is just partly health versus economy. It's also health versus health and economy versus economy, these kind of trade-offs. Also because, of course, the transmission can, or high level of transmission can harm the economy irrespective of the kind of interventions there or these heavy duty interventions. So that's the most obvious dilemma that I think all of us are discussing these days, and that we're trying to balance. Actually, as we speak, or while Hans was speaking, the Norwegian Prime Minister had a press briefing informing about how the Norwegian interventions are changed and the schools are about to open again. So this is, of course, a continuous evaluation of the set of interventions that can bring us to the desired rate of transmission or below the desired rate of transmission. And then while a lot is happening between these two cells, of course, it's also we need to have in the equation the positive effects of some of these interventions, including on the environment, in how we might, get more used to use digital tools and so forth, as we are doing right now. And then, of course, also think about the negative effects of some of these interventions on the transmission, in particular, the distributional effects in terms of moving transmission elsewhere, for example, by closing schools, whether people in the extended family or the neighborhoods or grandparents are more at risk and so forth. So it's important to not only look at the green and red cell. And then I just listed up 4 points next to that table to indicate concerns or considerations that you might see as integrated in that table, but can often be too easily forgotten. So one is individual rights, both as part on the basis of national law and human rights. Another is international law, obviously, which is another constraint. The international health regulations being one of the most important, along with human rights law. Then distribution, which of course is a key considerations for us, all of us concerned about priority setting and how different groups are impacted differently. And that, as we know, is true for the risk of disease and the risk of poor outcomes, but also the risk of being harmed by these public health measures. Obviously, staying home orders impact differently those that can work from home or will have sufficient income or household income even if they stay home compared to those that don't. And then process, I think not discussed enough how to involve the public in deliberations about what interventions to choose. In particular, how to involve the community in getting ideas for how these public health interventions can be as least harmful as possible in their applications. And then finally, a dilemma regarding communication, which is obviously how much of these difficult considerations to expose and have in the open, and how much uncertainty to communicate. And I think from the Norwegian side and the Institute side, we have chosen a route where we are very open about both these deliberations and the uncertainty involved in basically all of these interventions. So that's a very superficial overview of some of the key considerations, probably open for obvious for all or most of you on the call, but then Atle will say a bit more about school closures in particular. So over to you, Atle.
Okay, I'll try to be brief. The situation in the world is that I think most countries have closed their schools down now. I'm not sure how the distribution is in Latin America and in Africa, but I know that in many countries there, the schools have closed down and there is basically lockdown all over the place. I saw estimates that 800 million students don't go to school now or something like that. So it's a big intervention that has been implemented all over the world. And the obvious goal of this is to stop transmission by not having pupils and staff be together at schools. And also, which is also an important thing to bear in mind, is it's one of the goals is to have less communication travel to and from the home and to the school. So it fits with asking people to stay home. Now, school closures have been used, not a lot, but they have been used before, typically in influenza epidemics when they are large scale and to prevent transmission of the virus and the disease. And the evidence on how well these school closures have worked in terms of preventing the spread of influenza, that evidence is uncertain, as it usually is, but there seems to be a reasonable consensus that it is an effective intervention to stem or curb the spread of influenza, but that's not the same as COVID-19. So as many of you have touched upon, and as you always do in priorities, is setting exercises, there's an issue of benefits versus harms. And the benefits are obvious. You get fewer cases, at least you hope so, and then you get fewer hospitalizations and you get fewer deaths. And that's the whole point of school closures, I believe. And then there is a long list, which it's a long list, but it doesn't necessarily mean that they're more important, but there are possible harms of school closures. And this is basically me listing up what I've found reading the literature and following the media debates, because the debate has been heated in many countries and also here in Norway, which has probably led to now partly led to the government now opening up a little bit. There is this issue about positive and negative effects of school closures and lots of other interventions. So some of the points that have been raised is that when you close schools, obviously children are deprived of social activities, they miss out on learning. Not so much in Norway, but many other places, losing out on school meals can be very important, especially in the socioeconomic perspective. Then you have the more child protection perspective, which, and that point has been made, that many children live in under very difficult conditions in their homes, and they need the schools to have follow up from their teachers and as some sort of space where they can be an important part of their welfare is going to school. Another concern that has been raised, at least here in Norway, is that there is a worry that there are children who are now suffering under different conditions in their home and in their family, more or less because of the situation that has risen with more people out of work and that sort of thing under the epidemic and under the lockdown. And these children go undetected. Nobody knows about their troubles. If they had been going to school, teachers could have picked them up and could have helped them, contacted the child protection service if necessary, etc. There are observations. There is data that indicates that these problems might be real. It's difficult to assess the size of the problem, but there are reports that there are no children or very few children coming to hospital with signs of abuse, where there used to be much more. What does that mean? There is concern that this is going under the radar, so to speak. Trygve mentioned the risk of having extended family, grandparents taking care of the children, and then if they're infected instead of the children infecting each other, that might be a bigger problem than the children infecting their each other's. And then the obvious issue of preventing parents from going to work. That's a downside of school closures. So yes, this typical situation. And so the case summarized for school closures, and I'm sorry if there are important points that I'm missing, but these are the ones that I think sort of sketch out the big issue. Yes, the benefit is that we prevent the spread of the virus. However, that benefit is likely to be quite small. We don't know this, but it's likely to be relatively small, much because children seem to be not very infectious, at least not compared to adults. But it's not likely to be zero, so it is a likely benefit. And in terms of the harms, it's also very difficult to quantify. We don't know. It's very likely that the harms are real in terms of how children are affected, but to what extent, that's very, very difficult to say. In terms of economy, there have been exercises to try to model how much. Everybody agrees that this has a huge economic impact, but how huge, that's difficult to say. And then, so you have to weigh not only the outcomes, how you value the different outcomes, that can be done, I guess, but it's difficult to weigh them against each other when you don't know how large the impact are in terms of each outcome. So that makes decision making extremely difficult. And I've felt sorry for the government who's been sitting this weekend to discuss whether or not to reopen the schools. And not surprisingly, as we heard from Trygve just now, they've opted for some sort of middle way, which I guess indicates that they don't really know what to do. So they've opened the schools for the youngest children, which is assumed to be the safest route. There was, should mention that yesterday in one of the Lancet journals, there was a rapid systematic review on the effects of school closures for COVID-19. Of course, there's not much evidence, but what they find indicates that it's not very effective, but it's hard to say. So I feel that what I'm saying is basically echoing much of what especially the two first presenters commented on as a big problem under situations like this, when you have to prioritize, is that you don't have the evidence you need to make evidence-informed priority decisions. And that is a big issue, and I'd like to tell you about probably failed attempts to improve that. We've prepared a protocol to run a trial to assess the actual impact on school closures, but it probably won't happen, so it won't help much. Thank you.
Thank you very much, Atle and Trygve. This was very interesting, and it's, as you say, closing schools are happening in many countries, and also looking at and the uncertainty of harms and benefits is high, and also if you look at the potential harms in lower income countries, I guess they may even be higher. The Wi-Fi access in these households is not there, and you don't have the strong welfare systems when people lose jobs, parents coming home without a job and no Wi-Fi and teachers to follow them up. So I guess the harms are maybe much more severe, and it's interesting when you now say that maybe the health benefits are not that convincing, but of course we don't know. But now I would want to give the word to Amanda Glassman. She's from Center for Global Development in Washington, and she is a very experienced person in global health and have worked in all kinds of places, and I really trust that Amanda will be a good moderator. And I'm sorry, Amanda, for being late. We are beginners in these webinar things in the society, but I am open to continue after 5 o'clock, and people are free to leave, of course, but that depends on your time and availability, Amanda. So please, now we will have a discussion with all the presenters, and you are all, you can all type questions in the chat, and I will try and help Amanda and send questions to her but she will now lead the discussion. So thank you, Amanda.
Thanks, Kjell-Arne, and hello to everyone. Someone on the chat has said, well, Sweden hasn't closed the schools. We could compare to Sweden, which is an interesting idea. So we have, unfortunately, I do have to drop off in about 10 minutes, but let's just get started. We're talking about an enormous amount of decision-making and uncertainty. We do know actually quite well what the costs and harms are of a lot of the non-medical interventions. So perhaps now we need to understand what the level of benefits are available from that. But let's start with couple questions to the whole panel, and maybe we can just take them in turn. There's a question from Michael Chaikin about how generalizable are assumptions about the effects of school closures on kids and parents' behaviors between richer and poorer countries. This is directly from this conversation we've just had before. But also, even in a high-income country, we have to consider next waves, where as South Korea is currently experiencing, we're starting to see perhaps an increase in the cases again. And Adle, you mentioned the idea of to collect data to be able to do some kind of empirical experiment in lieu of just modeling. So how can we think about this if we're into COVID-19 for the long term? Can I start with let's say Juan and then Hans and Atle to reflect a little bit on this issue? Thanks.
Who did you want first, Amanda?
Let's start with Juan and then Atle.
Okay, someone said Korea is increasing again in the new cases, but it's not yet. It's still plateau. It's a 2-digit. It's now around 50 per day. We wish to lower than 50 per day, then we will loosen the social distancing more. However, still we are keeping social distancing, including school closure. Our school closure was not actively done because our the epidemic period was normal, ordinary winter break time. But what we did is extension of the winter break for some weeks, and eventually we decided to not to open, but to cyber open, so that every student are now running by the Wi-Fi basis at the home. So basically, it's basically it became the school closure inevitably. But except that school closure, the other social activity is not really social distancing, even though terminology itself is social distancing, even in Korea in the direct translation. But real meaning is very soft social distancing, almost close to physical distancing, with the still social network is keeping. So I believe this less softened version of the social distancing might be one of the possible role model for long-term sustainability of the epidemic control in other countries, because many of us told about the non-health the risk of this social distancing. That's huge. So that considering that, we can trade off between a soft version of the social distancing. That can be our running point to the rest of the countries.
Thanks. So yeah, I've thought a lot about how we could get more empirical data on all these huge interventions that have all these potential impacts in all sorts of directions. And I think it's particularly important then to try to estimate as well as we can how efficient these interventions are in terms of preventing spread of the infection. But it's obviously very difficult, because to get really trustworthy findings, you need to do some sort of comparison that you believe in, and that's very difficult to compare time periods, for example, when we know how an epidemic can vary across time, and then comparing something before and after, it probably doesn't make much. It will be very difficult to get reliable estimates, and then it's the practical barriers to running traditional controlled trials. I think school closures is one of the things that is technically possible. What we suggest is basically randomizing all the municipalities in Norway. There's 350, and half of them could reopen the schools and the others could keep them open for a month or two. I think that's technically feasible, but the main challenge there is probably acceptance in the population and among decision makers. And for the other big interventions to promote social distancing, I think it's very, very difficult to picture any way of having concurrent implementing different systems across the country at the same time. I think it will be a huge communication challenge to say that in some communities you can do one thing and in some communities you can do another. But I think it's worth reflecting on, and I think if we want to move this forward, the idea of getting more reliable data on this, or more solid evidence, we need a public debate about how we can go forward to do that.
Yeah, definitely. And I mean, perhaps the population's appetite for some of this kind of testing in real time would increase if people understand that the duration of this process is much longer than anticipated. You know, it's not Easter, as the U.S. president has noted. I'll pick up on a last point that you're making about communication with the population, and that Lydia has talked about, Lydia Caparuri on the chat. She's asking about the publicity and communication of decisions, the criteria, even for something like bedside triage. The rationale is quite important when we think about fair priority setting. Trygve raised this. And so the question to the panel is, what are the experiences that you've seen in high income countries? What should be publicized? What looks like best practice? I understand Ingrid sent me on the private chat, there's a document in Norway that talks about criteria, and there's a guideline that came out after a short hearing. But how should we be advising countries, especially where the triage is going to be much more dramatic? And maybe I'll ask Malit too, is the Africa CDC thinking about some kind of clearer guidance on triage, given what we're learning from the high income countries? So start with maybe Hans and then go to Malit.
Yes, it's difficult questions, because I feel it's so difficult to compare the lower middle income countries with the high income countries. But speaking from my perspective, we have had a process on this for the last 20 years, and it's been initiated by our health authorities. And we eventually have no regulation that says that no citizen in Norway can demand a treatment that the physicians are saying this will not work for you. So you can't come and say, hey, I want to have this operation, or I want to have this intensive care bed. It has to be deemed appropriate, and that you have some benefits from it. If you don't think you have some benefits, you cannot demand it. And this has been embedded in our population now. There are very little uproar when we know, for example, publish the present guidelines, how we will act in this pandemic. There are, of course, individuals that are against it, but in general, they accept that we have rules. And in particular, when we don't put age as priority one, but rather frailty and burden of disease, then I think it's much more acceptable. And this could be well performed in other countries as well. What do you think? The American perspective would be interesting to hear, Amanda.
Well, wait, let's go to Malit first and then we'll come back.
Amanda, we've started the discussions at Africa CDC. We're trying to put together guidelines, but the discussion, I mean, the questions have been like really tough, and it's not also very easy to adopt some of the best experiences from elsewhere, from the high income countries, because obviously we have like a completely different settings. So what I could say at this point is we really need to see critically this issue of rationing of care and come up with recommendations. But we are at the very initial stage at the moment.
Thanks, Malit. I mean, I think, well, in the United States, maybe this is the time. An optimistic take is that governors of some states, especially those that have more constrained supply, will begin to understand that a fair approach to rationing ICU care is necessary. And also, I mean, even in the UK, which does have some tradition of rationing care, at least at the health system level, is beginning to recognize that they are trying to intubate every person who has no chance of recovery, and that actually might make death rates worse in the meantime. So people are dying with COVID, not necessarily from COVID. So, but the problem with the United States, of course, is that we don't really have a health system to speak of. We have a number of, we have lots of different providers. They don't all operate together. There's some evidence that that is starting to change, which is a silver lining to a terrible situation. Yeah, I mean, I think unfortunately what we'll see this to play out is kind of a classic priority setting, a lack of a rationing without rules kind of results, where we're going to apply the rule of rescue, but on a first come, first serve basis, with pretty bad outcomes. I think we can see already, especially in the Chicago Tribune piece that you've just highlighted. But elections are in fall, so we'll see how that goes. That's quite discouraging right now. There's Kil Arne has just flagged for us that on the prioritiesinhealth.org website, there are some guidelines from a number of countries that could be useful when we think about this. But one other point related to this that Marta Gold raised on the chat, which I think is quite important, which is that what the level of the number of cases in healthcare workers can be high. And the question is, if we don't have an enormous amount of ICU supply to provide to complicated cases, is it worth the healthcare workers being exposed at all? I mean, they're going to be exposed to some extent, but is there some, in low middle income countries, should we be thinking about special dedicated COVID-19 facilities that, minimize healthcare worker exposure? These are very difficult questions to discuss, but I don't know, Marlies and Malit, if you have any thoughts on that.
Malit, over to you and I'll follow on. I think Malit is muting.
Yeah, it could be that she's muting, but I also know that she is immensely busy, so it might also be that she had to leave. I'm not sure.
11 arrived. So maybe Marlies, if you want to reflect a little bit on, we don't have much data coming from low middle income countries yet. So there's humongous uncertainty, but at the same time, given the importance of sustaining existing cost-effective healthcare services, what exactly can we advise some of the lowest income countries as they think about how to respond to COVID-19?
Yeah, I mean, I think clearly, and there's WHO guidance on this, Amanda, I think clearly we can't tell a government, stop vaccinating your population, stop providing insulin to diabetes patients, etc. I think it's more about thinking where and how those services are provided, which is why I think that it is so important that we rapidly think about standing up very basic telemedicine services that require some regulatory approvals in some countries, but I think if there's a will, there's a way. And that's one of the things that we think is essential. That said, I will also say that what we have seen so far, and so far the confirmed cases are low, as Malik pointed out, but increasing. But what we've seen in other places is that people, just as people vote with their feet, people stop going to facilities, right? Which is not always a good thing. So we need to concomitant to these efforts, focus strongly on what is it that our community health workers can provide, etc. Yeah, I will also say that this is going to be an ongoing topic of discussion, right? You know, in 6 months from now, we're going to know infinite amounts more about this virus than what we know right now, and thinking about how to right size within an overall health strategy, you know, treatment and prevention of and treatment for acute respiratory disease versus everything else. I think some of these questions are going to become easier as we learn more about the spread, about mortality, and you know, about seasonality, about duration of immunity, about the effectiveness of serological tests, and if we can get their specificity and sensitivity right. All these things is going to help us to think about how do we provide these services, right? But I could imagine that a community health worker who has recovered immunity and who can do things like basic vaccinations and distribution of chronic disease drugs can fulfill a lot of requirements or a lot of services that people typically would have gone to a health facility for, right? And I think that it's this unfortunate time of opportunity that's been forced upon us by this pandemic, is to think about changing service delivery modalities whilst ensuring that we're encouraging those basic services, because we don't want mums to be too scared to take their kids for vaccinations when they need those vaccinations, right? So it is a very difficult balancing act. And I think the advice we're giving governments is think about your other services and how you're delivering them, and if things can change there.
Yeah, so thank you, Marlies. Now Amanda had to leave us, and Marlet has left us. So I think that's a signal that we may end this meeting for all of us. We could, of course, continue for hours and hours and discuss this, and there are lots of topics. So I hope that in the society that we will be able to continue to have these kind of pop-up seminars. And if any one of you are interested in organizing a pop-up seminar on any particular issue, you can contact me and I will help you to organize it. Now we have found some kind of a technical solution that works fairly well, but we are open to feedback. So please email me any feedbacks about this web conference. It's our first time, but the presenters, thank you very much to everyone. You did an excellent job, and I'm so impressed by the quality of your talks and the slides, given that you all are busy dealing with actual hard priorities and other types of work. So, and also thank you for your flexibility of showing up on such a short notice. I've been pushing some of you a bit hard to present, but thank you for doing this. And I hope that we can have another conference. But now I wish you all a good Easter, and I hope that you will all take care. And I am sure that we will be back with a new COVID conference. So thank you. Bye-bye.
Thank you. Bye.